Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director at Healthcare Improvement Scotland, and welcome to this, the seventh in our exciting lineup of QI Connect WebEx sessions for 2016. QI Connect provides an opportunity for colleagues from across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. We've designed these sessions to be short, accessible and recorded to allow access at a time that suits QI connectors best. And I'm just going to say good afternoon to Jennifer, and Jennifer's going to say a little bit more about the WebEx. Good afternoon, Jennifer.
Thanks, Brian, and welcome everyone to today's session. So I've just got a couple of quick housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. And if you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience, so we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. And there will of course be an opportunity for Q&A at the end of the session. So if you just click on the chat icon that I've circled here in red, which looks like a speech bubble, and you just type your message, send to all participants, and that's you. We'll also be sharing hyperlinks within the chat function throughout the session to any resources mentioned by our speaker today. Okay. So here is, we did say it's going to be an interactive session, so we're delighted to be joined by so many people all over the world today. And we're just going to ask if you can just tell us where you're joining us from. So if you can just click on the pen icon that you can see circled in red here, which is the top left-hand side of your screen, and then click on the arrow, and then click on your location.
Well, Jennifer, it looks as though it's just me at the moment, but we know that's not the case. So we're just waiting for the rest of the arrows. Hi, Nancy. Welcome aboard. Good to see so many folks from across Scotland and Northern Ireland, colleagues in Canada. Good to see you all joining the call. We've got folks up in Orkney. Good afternoon, Caroline, over in Orkney. We've got Rosalind in the middle of the Arctic Ocean. So welcome to you also. And Frank, welcome Frank, and welcome Maureen Bisignano over in Boston. Frank, looks as though you're in the middle of the States. Welcome, and great to see you all join the call. Thank you very much indeed, and stick with it and keep those arrows at the ready. Thanks very much, Jennifer, for that introduction. And we really want to see a lot of activity in the chat box this afternoon. We'd like to thank Stephanie, our BT coordinator, for working with us on the chat box as well. Good to see so many colleagues from the US and North America joining us as well. So, as you know, QI Connect has been running now. This is now our 26th episode of QI Connect, and we now have a record-breaking 448 organisations who have signed up for QI Connect, and we'll hear more about them in a moment. However, this is the thing that the QI connectors really wait for at the beginning of all our calls, is the competition. So what we're going to do is we're going to use that arrow function again, and what I'd like you to do is, these are the countries that sign up, now 47 countries for the QI Connect series, and I'd like you to get your arrows at the ready and to put your arrow on the flag of the country I'm just about to name, and the first person gets a wonderful prize. So the country I'd like to name today is Sweden.
That one there, Sweden. Well, you might, it was on your email, but it'll be one specific to you.
We're just waiting for those arrows to come in. We feel sure there's an arrow coming any second now. There you go, Gavin Patterson. Well done, Gavin. And everyone's got it right. Thanks very much to all the rest of our colleagues, Sharon Robson, Tricia Morrison, Michael Smith, and the rest. But welcome, so well done, Gavin. And of course, you get to receive one of our wonderful QI Connect mugs. That will be winging its way to you just now. Thanks very much for that. So those 448 organizations that link in, we're delighted to have your logos. When we started the organization, the QI Connect series, sorry, we just had one page of logos. This now runs to more than 30 pages of wonderful logos from all over the world. We're really grateful for you for joining and making the QI Connect series the way that it is. And we're always delighted to welcome all of our colleagues in NHS Scotland. Every board in Scotland joins into QI Connect, and we're absolutely delighted today. In fact, the Chief Executive of the NHS in Scotland, Paul Gray, is visiting with Healthcare Improvement Scotland at our site over in Edinburgh. So welcome to the team who are over listening, possibly including Paul this afternoon. And we're always delighted to shout out the universities that join the QI Connect, and we've got almost 40 universities that join the QI Connect series. Delighted to have the university, the Queen Margaret University in the United Kingdom, joining us for the very first time today. Absolutely delighted with that. And a special mention to all of our new QI Connectors from all over the world. We've got folks from the UK, we've got colleagues from Sweden, we've got a wonderful company, organisation called Upstream Dream in Sweden, so you're very welcome, and colleagues in North America, England, and in Canada. Big shout out to the International Network of Agencies for Health Technology Assessment. You're very welcome in NATA. So you're all very welcome to this QI Connect episode. And as you know, we're recording the episode so that this can be used time and time again. This is a picture from Ko Awatea, our friends in New Zealand, who use the recordings, as many of you do, for follow-up learning. And all of our recordings, going all the way back to the first episode, are freely available on our website, and we encourage the use of the recordings. You're welcome to them. And of course, our friends in ISQA, the International Society for Quality, use our WebEx series, our QI Connect series, for their fellowship program, and again, delighted with that. And of course, the team here is a small but perfectly formed team. You've heard from Jennifer. We also have Ross Stewart in here, who deals with all the administration and all the certification, and delighted to also have Alex Sterling, who is our Twitter analytics lead, and very welcome to the team. And today, as you know, the format for QI Connect allows us to have a first questioner, and today we have Dr. Sanjeev Chauhan, who is a consultant anaesthetist and a Scottish Patient Safety Programme Fellow from NHS Lanarkshire, and we'll hear a bit more from Sanjeev a bit later in the call. However, don't forget that we're on Twitter and the hashtag HISQIConnect, and please follow us at HISQIConnect, a very active Twitter group, very keen to share as widely as possible using that medium. And of course, that then brings us on to today's QI Connect, and I'm absolutely delighted that today's QI Connect speaker has joined us. He knows a thing or two about whether health and care systems offer value to users, customers, and providers. Professor Jean Nelson has been a pioneer in bringing modern quality improvement thinking into the mainstream of healthcare. He was involved in the development of the Institute for Healthcare Improvement, and was a founding board member there, and continues to work collaboratively with IHI and many other quality improvement leading organizations across the world. He's authored more than 150 publications, including 3 groundbreaking books in the field of quality by design, with a focus on improvement that actually happens at the coalface. I'm absolutely delighted to introduce my friend and colleague, Professor Jean Nelson. Good afternoon, Jean.
Thank you, Brian. I am delighted to be here. It sounds like we have an echo. Sound check. Am I coming through okay?
Lost the echo.
Okay, very good. So thank you for inviting me to be part of this global WebEx program. I'm delighted to share some ideas with you. And the topic for today is learning through co-production, a model for improving health outcomes, healthcare services, and research. It's been a bit of a wild ride, sort of like Mr. Toad's wild ride. And I'll give you a quick backstory on how this work started. About 3 years ago, I received a phone call from my friend, colleague at the Robert Wood Johnson Foundation, Laura Leviton. And she said, Jean, would you like to help the Robert Wood Johnson Foundation import an innovation? And she went on to say that the innovation they were interested in importing, if you will, into the United States was the Swedish Rheumatology Quality Registry. And I said, definitely, I'd be very interested in that because I had known Stefan Lindblad, who was the founder of the registry for many years. And in the late 90s, Stefan was visiting us at Dartmouth and saw what was happening at the Spine Center and said we could do this in Sweden, and they did. So what Laura was talking about, the idea of importing an innovation, was the Swedish Rheumatology Quality Registry approach. And there is a wonderful video that is shown on this web link that describes the approach in a brief video, and I'd recommend it to you. And what you see in this photo is a patient registering her own data on swollen and tender joints on a touch screen. So the work of the SRQ begins with people who live with a chronic condition who are able to report on how they are doing. There's a patient module whereby patients indicate their health status using a health-related quality of life questionnaire called the Health Assessment Questionnaire specific to arthritis, and show where their joint pain is, how many joints are involved, and that creates a dashboard for self-management at home in between visits to a clinician. There is also a clinician module, and this is used by the clinicians to track outcomes over time against treatment plans and specifically medications, so that in the clinician module you see the clinical outcomes over time, the patient-reported outcomes over time. You can see they tend to be associated, and what medications were taken at any one point in time, so that you can start to put together health outcomes as they're evolving over time against treatments. The most important dashboard, if you will, in the Swedish Rheumatology Quality Registry program is quite simple, and this is a view of it. And what you see here in the columns are dates of visits. So this is you can think of it as a co-production dashboard used when a person with a rheumatology problem gets together with their clinician or clinical team. And what this, each column shows how health status is at that point in time using both clinical metrics and patient reports. So, for example, CRP is C-reactive protein, a blood test result showing disease activity, and the HAQ is the Quality of Life Questionnaire, or the EQ-5D. And then on the bottom, there are the different medications that are prescribed at a point in time. And it's color-coded, as you can see. So this one individual was in yellow in September and October, turning to red, which indicates a flare-up, an exacerbation of their rheumatoid arthritis. And a medication change was made. A different biologic was prescribed in December, and that was associated with better results and much better results by February of that year. So this is you can think of it as a point-of-care co-production dashboard, very simple and very powerful, and clinicians and people living with the condition learn how to use this to good advantage. In the Swedish Rheumatology Quality Registry program, it started in approximately 1995. Today, in 2016, it covers virtually all of the people living with a serious rheumatology problem in Sweden. So there are 70 different diagnoses, and one of the largest groups, of course, is rheumatoid arthritis. What you're seeing on this trend line goes from 2005 to 2014, and it shows the proportion of people with a flare. And so in 2005, it's roughly 11% of the people in Sweden in the registry with rheumatoid arthritis having a flare. And that red line you can see is gradually working its way down, and it's essentially cut in half by 2014. So that the rheumatology registry approach has been associated with better disease outcomes in the Swedish population. What you see in blue gets to the quality improvement at the front line issue. The line represents RA patients in Gävle County. In approximately 2008, Dr. Sven Tedmark became the new clinical program leader for rheumatology for Gävle County. And rather than just recording the data and using it for research, they started using the data actively at the point of care so that clinicians and patients were using the registry data to track in real time, close to real time, outcomes against treatments. And they also started to encourage the self-management at home using self-tracking across all of their centers in the county. And that was, you can see the high variation and often higher rates of poor results dropping to be as good and often a little bit better than the rest of Sweden when the registry that had been used heretofore for research was used at the front line for patient care as well as for home management. As we started looking at this Swedish Rheumatology Quality Registry approach, we recognized that the same kind of approach was novel but not unique. In the United States, a network called Improve Care Now for children with inflammatory bowel disease, started by Peter Margolis and Dr. Richard Colitis, has been working since about 2006, and this is their trends in remission rates over time for children with Crohn's or Colitis disease. So the remission rate tracked monthly across the network has improved from 55% in 2007 to 78% in 2015. It's slightly higher now in 2016. And there were 30 practices in the network originally. Now there are over 80. And quite remarkably, over 70% of the patients achieve remission steroid-free, which is really wanted and appreciated by the patients. So a similar approach taking a root in the United States, showing that this kind of approach may make a big difference in patients' health outcomes. When you look in on the Swedish Rheumatology Quality Registry, or you look in on the Improve Care Now network, what you can start to see is something you might describe as a registry-based learning health system. And at the center of the system, there's a partnership. We'll call it a partnership between the patient and the clinician around co-production of health and healthcare services. And informing that partnership for co-production is an information environment. We'll call it a dashboard, which can show at a point in time and over time outcomes against treatments. And so we feed forward the patient-reported outcomes, point in time over time. We feed forward the clinical outcomes, point in time over time. We create the dashboard used for self-management at home and for co-management when a patient is directly interacting with a physician or a nurse. And the dashboard catalyzes potentially a better relationship, better decisions, ability to track outcomes, and have won over time. Then the system works as a learning system in a couple of very important ways. So on the right-hand side, there's a collaborative improvement network that brings together different clinical teams and clinicians in the network virtually as oftentimes as well as face-to-face. And the information database shows how each clinical programs patients are doing relative to the others for improvement and learning. On the other side, we have the patient-facilitated networks, which are emerging quite rapidly, where curated patient-facilitated networks enable people living with a condition to connect oftentimes with the internet 24/7 with other people like them, to share knowledge, to share support, to get ideas, and to have access to curated information on different treatments and different approaches. So a patient-facilitated network, a collaborative improvement network, is fed by the database that's produced at the point of care. And that is the platform for a registry, which traditionally has often been used for retrospective research or as a platform for prospective research. The goal, of course, of this is optimal health needed and wanted by the individual and high-value care for individual patients and populations. So that's a conceptual model of what we see when we look in on an organization such as the Swedish Rheumatology Quality Registry or look in on the Improved Care Now network. A new word for some of us is the term co-production. Paul Batalden, friend and colleague, has said this: all services at some level are co-produced. And that is to say that the health outcomes and the healthcare services for most people with chronic conditions, most of the time, has to do with this interaction of individual with professional. Very important and powerful concept actually popularized by Ostrom, the Nobel laureate in economics, coined the term co-production. This idea is moving ahead. It's catching on. This is Dr. Dino Kazi, professor and the head of the Arthritis Registry for the American College of Rheumatology. He says, I dream of the day when I can electronically display both clinically derived and patient-reported information to the patient at the time of visit and make a meaningful patient-centered treatment plan co-produced with the patient. The model also puts form and function underneath the idea of what the Institute of Medicine has called a learning health system. And the Institute of Medicine describes a learning health system as something that generates and applies the best evidence for the collaborative healthcare choices of each patient and provider and drives the process of discovery as a natural outgrowth of patient care. So if you reflect back on that conceptual model and how that works at different levels, level of an individual patient, the level of a clinical program for program improvement, and at the level of a research scientific network, you can see that one way of putting a learning health system on the ground would be to adapt this model to your situation. Some of the potential benefits of this approach, listing here 6. First, to improve outcomes for people with a chronic condition. Second, to improve the quality for practices and clinical programs. You saw the Gavle example. Third, to promote practice-based research and to advance science. The idea of registry-based RCTs and learning from every patient is an idea whose time perhaps has come. Fourth, to advance patient-centered facilitated networks. These have been around for a long time. The first one I became aware of was started in 1990 for women with breast cancer. And you could think of Alcoholics Anonymous as a facilitated network. So these have been around for a long time, but have often been on their own, not part of a connected and larger system. Fifth, fostering continuous professional development. So the ability to improve your own practice based on knowing your outcomes and your processes and what you might do to improve your practice for your patients is a feature of the model. And very importantly, a byproduct of this system can be transparent public reporting, as is being done in Sweden with the Rheumatology Quality Registry and with the Improved Care Now network. So those are some of the potential benefits. So to recap, we learned about an exciting approach being used in Sweden. We looked at it as a potentially generalizable and adaptable model. And now our work is focused on proofs of concept, so that in the United States, we're working with 5 cystic fibrosis centers that are part of a 168 national network to start adapting the approach. Also in the United States, we're working with 20 pilot practices, adult practices taking care of people with inflammatory bowel disease. There are 2 practices now using the approach. There will be 20 by December using the approach. There is a similar program that we're collaborating closely with in Sweden for cystic fibrosis that Andreas Hager and others are leading in Sweden. Same approach, different place, different adaptation. So you can see something starting in Sweden, coming in the U.S., going back to Sweden. And we're just starting new programs, proof of concept programs with the Arthritis Foundation and the arthritis community in the United States. And a similar project also in Sweden with juvenile JIA. Key collaborators, different foundations are part of the partnership arrangement. Important medical groups in the United States, the American Board of Medical Specialties, the American Board of Internal Medicine, the American College of Rheumatology, for example. And also IT vendors and in future payers. Payers have been at the advisory table, and we hope that that we'll be able to involve payers in value-based payment programs in future. At the heart of the proof of the concept is co-designing the adaptation of the approach to the context, to the population, involving patients and parents when relevant, of course, clinicians, registry leaders, and scientists, and then testing the model in diverse settings, prototype, alpha, beta, spread, Batalden might say from small to all. The next few slides will give you a sense of what these dashboards are looking like for these proof of concept programs. This is a schematic of what is now starting to be tested in CF in the United States. And in the center of this view, you see mental health outcomes tracking over time, physical health, and well-being, alongside clinical outcomes, FEV1, lung function, and body weight. So in the center view, for use when a person living with CF is seeing their clinician or clinical team, we have outcomes over time. On the left side of the dashboard, the idea of setting up a co-productive conversation. So the patient indicates what their concerns are, what they'd like to discuss at that visit, and any special requests they have with the care team. So that's fed forward for the visit. And then as the visit progresses, the conversation takes place in light of the current health and that individual's priorities and goals. What's the best care plan for them now? What are the next steps? What can we agree upon? What barriers might be expected? And then the individual is ready for the next phase of their care through self-management and co-management. I'm going to click through these, and a second level dashboard will show what you saw earlier in the Swedish Rheumatology Quality Dashboard, showing how different treatments are affecting different outcomes, and then the ability to drill down into important areas. In Sweden, there's a sister program that is being organized by Karolinska and the 4 care centers in Sweden that organize most of CF care. And here you can see Sonia, a young woman living with CF, with her a paper copy of her dashboard, and she's debriefing her mother on her cell phone about how her visit just went when she saw her CF care team. So similar idea being adapted in Sweden. For inflammatory bowel disease, this is the look of the dashboard, and this is now up in 2 practices, 20 by December. And what you're seeing here is the tracking of well-being, rectal bleeding, stool frequency, abdominal pain, and blood test CRP results, point in time and over time, against the treatments that are being agreed to and followed. So getting ready to wrap up now. We're on our final leg of this introductory presentation. The approach is meant to stimulate effective co-production. And here's some early quotes from patients and clinicians about co-production of healthcare services and health. So, patient side, helps me move from feeling guilty, it's my fault that I'm in the hospital, to how can we fix this together? My doctor trusted my expertise and recognized my talks, part of my job, are important to me. Can't build on broken, so focus what we have as strengths. Another person, I do a lot of tracking. I can solve problems by tracking. Last, they heard me out before responding to my concerns, didn't brush them off, and responded with a solution supported by similar cases. Some comments clinicians have made, each visit is a 20-minute sprint, and now I feel like I'm getting a head start. We're already doing co-production, we're just doing it poorly. Having the dashboard gives me a hard stop before going in to see the patient. I see what their goals are and what they want to get out of the visit. Another comment, it's like having 2 experts in the room. And finally, without my dashboard, I can't be a good doctor. I'm flying blind. So, in summary, we think that using the model in American parlance sets up a triple play in baseball, it's possible to get 3 outs and end an inning in 1 play. And this is a picture of the Boston Red Sox getting a triple play, going from third base to second base to first base. And the triple play potential with this kind of approach is co-producing healthcare services, and patient daily care capability. Second, co-producing quality improvement and professional development. And third, co-producing research and scientific knowledge. The idea is catching on. This is an article that came out just July 1st in the British Medical Journal that summarizes what we've covered here, titled Patient-Focused Registries Can Improve Health Care and Science. They have the potential to do so. As always, the work that I'm describing has a lot of people behind it and important support. And later on, if you're interested, I've included some selected references that you might want to take a look at. So that's a conclusion of these overview remarks, and I'd like to open it up for discussion.
Brilliant. Thank you very much indeed, Gene. That was tremendous. A really nice description of the journey that you've taken together with colleagues in Sweden, North America, and elsewhere. So really tremendous, and you even got us into the Red Sox, so that can't be a bad way to end a talk. Now, let's just bring back in Sanjeev. Good afternoon, Sanjeev. You may be muted, Sanjeev. There we go. Sanjeev, are you with us on the call? We've got seagulls, but no Sanjeev. Okie dokie. Sanjeev, you may come through just in a wee moment, but we've got Sanjeev's question, I think, that he's just sent in to us for Jean. And Jennifer, you can just take us through that?
Yep.
Great. Sanjeev, if you do get through the call, or if Stephanie can help from BT, but meantime, Jennifer, how about the question that Sanjeev put through?
Yes, yeah, so thank you. Thanks, Jean, for a great session. So the question that Sanjeev had asked, I sent through was, is there a particular clinical area or group of patients with whom you would suggest we begin testing a system of co-production, and where is the most fertile ground?
Thank you. The basic approach and model we think could apply to anyone with a chronic disease, could apply to any chronic disease population. In many respects, the work of Ed Wagner and the chronic care model is reflected. Advisors that help develop this approach are primary care specialists. For example, Paul Miles, he thinks that this approach would apply to pediatrics and any child's care as well. Probably groups that might be most right for testing would be people living with chronic conditions that have a high need for capable, intelligent, effective self-management. And with clinicians who would like to try to be even more effective in partnering with their patients to get better results. So the need and the motivation factors.
Thank you very much for that, Gene. Just following on from that, I guess, Graham Cumming, who's an innovation champion in NHS Lothian, and also Andrew Winter, who's the e-health lead and sexual health consultant here in Greater Glasgow and Clyde. They raise a question about, so it looks as though areas like this and other areas like patient portals are heavily sort of supported by charitable organizations or mainstream health-related organizations, and he just wonders about perhaps rare conditions or people who may be excluded from this sort of development. Any thoughts around that?
Yes, we're starting with cystic fibrosis in the United States and inflammatory bowel disease and rheumatologic problems. These, as noted, are all organizations where there are strong foundations that are patient-facing and are relatively large populations. Cystic fibrosis, 30,000 people, inflammatory bowel disease, hundreds of thousands, rheumatology, millions and millions. But I think that this kind of an approach can be effective in communities of practice, I'll use that term for just a moment, of all shapes and sizes. So can apply to rare conditions as well as to common prevalent conditions. The need to bring together the people living with the condition and their families, or the value of bringing together people living with the conditions and their families, along with the clinicians and clinical teams that dedicate their lives to trying to make the patients' lives better, with the scientific community that is trying to develop breakthroughs and better care and services and treatments. Bringing those three stakeholder groups together can be done for larger populations or smaller populations.
Thanks very much, Gene. We've got a couple of comments here that relate to carers and patients and families and how they get more involved. Maureen Bisigliano, a person well known to QI Connect and indeed a close friend of yours, Gene, President Emeritus of IHI and a Senior Fellow at IHI. Maureen is sharing with us that she visited in Norway recently to a reablement team in Norway, and they described a fantastic example of co-production there. However, her question was, it would be interesting to ask about the assets that the patient and family see as the plan is developed. So what kind of assets would a family member or patient see?
That's a great point and a great question, Maureen, that outside of healthcare, there's a movement, if you will, around asset-based planning. And you actually saw that idea in one of the patient's comments about co-production, can't build unbroken. And so to Maureen's point, in many respects, what you're trying to do is to put a person in a position that recognizes their strengths and abilities and plays to that and tries to, when possible, compensate for areas that aren't current assets by building those up within the individual or the family or trying to make connections to get needed services, be they medically based or social services or education based. So starting with the assets of the individual and their family and their natural social network to co-create services and to try to develop the best desired outcomes is foundational, I think, in this view of health service.
Thanks, Gene. And on a related theme, so Florence Burke, who's the Chief Executive of Music in Hospitals. Welcome to the call, Florence. Florence is asking, how are unpaid carers involved in this sort of activity?
How are unpaid carers involved in this activity? As an example, in the Improved Care Now network that I mentioned, This network meets in face-to-face meetings, national meetings, twice a year. Parents, caregivers, patients, clinical teams, scientists are all there and part of the active community that is shepherding the work of that network at three levels: at the level of the individual, the practice, and the research level. So the caregivers in that group are at the table in every way in terms of organizing, governance, specific programs. And then on a regular daily basis, if we look into CF, the parent from birth until the child becomes an adolescent and is off on their own is the primary caregiver, and that primary role starts to shift to the adolescent living with CF, as we saw in Sonia's example, and then in a sense, the care team supporting the individual with CF is in a secondary and consulting role. So it's family and person living with the condition in a primary role for cystic fibrosis. In that condition, people spend up to 2 hours a day on self-care daily treatments. So the caregivers in that situation are deeply involved. That's, I think, an extreme example, but shows the degree of caregiver engagement in that particular condition. The work that is taking place in Sweden with the CF program and Genia is very much built around the family and the individual as primary caregivers, and the social network that they create, and the professional network that they plug into for health care.
Thanks very much for that, Gene. And excuse me, Katrina Hayes, who's an improvement advisor and statistician at Scottish Government, asks a question. She says, thinking of people with several conditions and who wish to be seen as people, not the condition, is it always necessary to do this based around specific conditions, or how would you see this going forward with people who live with multiple long-term conditions?
Yes, thanks for that question. My sense is that this is, in a sense, one of the highest need groups, people living with multiple and complex chronic conditions, that this is a major opportunity. It is a little more challenging because in CF or with rheumatoid arthritis, there's a focal condition, asthma. But in real life, when we look at our populations and the people with the greatest challenge and most in needs, it's people with multiple complex chronic conditions, often with social challenges overlaid or part of the mix. And so my sense is that there's an immense opportunity to adapt this approach to complex chronic patients. I was talking with a colleague, Dr. Steve Liu, who's ready to start Chapter 2 of his career. His passion is older people, frail elderly, if you will. And when he learned about this approach and this model, he said, this is fantastic. We've got to start using this with our complex chronic patients here at Dartmouth. So I think there's a tremendous opportunity there. It is a little more complicated and challenging, but could be very effective.
Thank you very much. And Jean, Natalie Weir, who's the pharmacy PhD student at the University of Strathclyde here in Scotland, is asking, are there any examples of this linking into other healthcare professionals, e.g. community pharmacists?
The short answer is that you wish to include all of the relevant health professionals in this view of your learning system, as well as social service professionals. If you, for example, follow the footprints of the individual living with a condition or conditions over time, what services do they seek? What services do they need? Follow those footprints in and out of different health and social care providers. And that starts to map what, I'll call it the mesosystem. It's the network of service professionals that may be needed to help this kind of person or this kind of population at certain points in time and over time. And what you would like to be able to do is to include all of those service providers in the network and start to move towards this idea of co-producing the services that cut across health and social boundaries. So a system that recognizes all of the assets that are needed and can bring them to bear in a way that helps individuals and brings them to bear in a way that can foster continuous improvement. And through this special data collection idea, brings them to bear to serve as a basis for research, for example, comparative effectiveness research on different interventions.
Thanks, Jean. We've got a number of questions, a number of comments, around some of the systems that we do have here in Scotland that work well, whether it's My Diabetes, My Way, or Renal Patient View. And comments in the chat box here around some really good work that's been taken forward by the Scottish Society for Rheumatology, and we have the President of the Scottish Society of Rheumatology, Liz Murphy, on the call as well. So lots of good examples here. However, Gavin Patterson, who's from the Health and Social Care Alliance in Scotland, raises a good point. He says, there are many systems which are still not widely promoted or widely utilised. And he makes the point that having the system there to support co-production is great, but we still need to continue to work on creating a culture conducive to co-production. I'm sure you would agree with that.
Yes, exactly right. That what we see that we're trying to move towards, you can say the words transformation easily, but actually changing habits and assumptions and ways of thinking and acting and behaving is the stuff of which transformation is made. And that does mean, to the point, does mean cultural change. Culture is about my identity, my roles, my beliefs, my patterns, and our patterns and beliefs and roles. So that moving to a potentially more effective system involves real change, and this real change can be supported by things like dashboards, but it's the real change in the local culture, actions, roles, beliefs, habits, assumptions that is needed and is desired.
And that is something, Jean, that's echoed in comments from Diane Murray, the Scottish Government Associate Chief Nursing Officer, who makes the point around the human behaviour changes that are required around this. And she asked the question, should you start with the willing few and the keen folks? It sounds as though you probably have with communities such as the renal community.
Yes, I think that my analogy is if it's a new test crop, start testing it in a fertile garden and then move to less fertile gardens. And I think, starting with patients, families, clinicians that sort of like the idea, find it attractive, and of course they see challenges, but they're willing to give this a try. So starting on a small scale with the early innovators, this is the way the dissemination curve usually works. You start with people that have the interest at that left-hand side of the diffusion curve, and you start working to the right on that curve. People that are a little less interested, and then the mainstream, and then getting to those that are most reluctant to try the new way. So get the bugs out, get the process and principles up and running and working in small locations with diverse populations and diverse clinicians. And then once that is working sufficiently well, try to spread rapidly to all. So the issues of diffusion and technical scalability become very important as let's say, step 2 in this kind of work.
Brilliant. Thanks very much again for that, Jean. And there's, again, a very active chat box around some of the available systems that we have here in Scotland. And Dave Garrell, who's a health outcomes consultant with Sanofi, making the point there's great potential around, for instance, My Diabetes My Way. And Jonathan O'Reilly, who's an improvement advisor at NHS Lanarkshire, just asking around whether these portals that we have here in Scotland are only available for clinicians or for patients and clinicians. And I think some of those points have been addressed in some of the links that we've put in the chat box. However, I can't not comment on Akin Akinola. Akin is a specialist doctor in Golden Jubilee Foundation Trust in Glasgow, and he runs the Improvement Club there. And Akin says, this is a brilliant concept we could hugely benefit from in the NHS. Should we not just set up a pilot like next week? So Akin is very keen, and we're delighted with that. And I'm also delighted with all the comments from Andrew Winter, the eHealth lead from Greater Glasgow and Clyde, and colleagues such as Graham Cumming, who's the innovation champion at NHS Lothian. They were both highlighting some developments that are happening here in Scotland, and a very interesting open invitation collaboration challenge for looking at self-reporting of symptoms with patients with inflammatory bowel disease, led by Professor Angus Watson in NHS Highlands. So it sounds, even from the chat box, as though we're doing a lot of good work here in Scotland, and your sharing of your experience, I'm sure will be landing on fertile ground. So Jean, it just remains for me to thank you on behalf of QI Connect. It's been wonderful to have your insight and sharing the insights of your colleagues in Sweden, North America and beyond. Thank you again, Jean. And
Thank you very much.
Yeah, you're great to have you on the call, Jean. And just to remind everyone that our next speaker on QI Connect is Steve Spear. Steve is principal at High Velocity Edge, based out of Boston. He's a senior lecturer at MIT in the management engineering schools. He's published widely and is widely known for his work in quality improvement in healthcare and beyond. We really look forward to speaking with Steve at the end of September. And just a reminder to everyone of the wonderful lineup of tremendously generous speakers that we've had this year in 2016. So Steve in September, an outstanding lineup in the 27th of October. We'll announce a bit more about that at the next QI Connect. And Peter Lachman, the new Chief Executive at ISQA, ending off the year at the end of November. So it just remains for me to remind you once again of the Twitter. Please keep joining us. It's been a delight to have you.